Hey, everybody, welcome. We are just past the part um, of conception. So, we kind of reviewed how important it is for mom to be taken care of in the different trimesters. Nutrition is still important. There can be trauma inside the womb. Some of our refugees at St. Leo's that were in a war situation, they had some PTSD. Trauma shows through when the baby was born. When mom has heightened cortisol, the baby also absorbs that cortisol. So, and I know we started on stages of labor, so birth, and there was quite a few that were helpful in here. And I wanted to show you some of these because they are very detailed.
Learning medicine is hard work. Osmosis makes it easy. It takes lectures and notes to create a personalized study plan with exclusive videos, practice questions, and flashcards, and so much more. Try it free today.
Labor, also called parturition, describes the hard work of delivering a baby. It specifically refers to the process which starts with uterine contractions, which cause cervical changes, which allow the fetus to be delivered vaginally, and ends with the delivery of the placenta. Labor typically begins at some point when the fetus is considered full term, between 37 and 42 weeks gestation. In the third trimester, before labor starts, a woman might have a plug of mucus and blood fall out of the opening to the cervix, sometimes called the bloody shell.
So that is a real life thing, as we thought we were going to have to induce our baby New Year's Eve, and we did. But before the pitocin kicked, my wife had her mucus plug fall out. That's actually what seals up the cervix when the baby is being born. And one thing that makes you shed your uterine lining is higher levels of not estrogen, but the other female hormone. I'm blanking on it now. So my wife did have to take the shots of that to tell her body it was pregnant and not drop the mucus plug, and then the baby stayed in. We had a couple miscarriages before that. So the mucus plug is important to keep the baby in and to not have the period.
Other times, the amniotic sac might rupture, sometimes called water breaking. Either of these can trigger the onset of labor and so-called true labor contractions. These guys have to be distinguished from the milder and ineffective false labor contractions, also called Braxton Hicks contractions, or sometimes called practice contractions. Once they start, true labor contractions progress in frequency, duration, and intensity, and they can feel like waves that build up to a peak intensity and then gradually decrease. The contractions pull on the thick tissues of the cervix, causing it to efface or get thinner, and also dilate or open up. So then, the fetus can leave the uterus and enter the world. From the moment true contractions begin to the baby's delivery, usually takes about 12 to 18 hours for a first-time pregnancy, and about half that time for subsequent pregnancies. Although, as any mother knows, this time can vary a lot. Even though labor is a continuous process, it can be broken down into 3 stages. Additionally, this first stage is subdivided into 2 phases. The first phase is the early phase or latent phase, and usually lasts up to 20 hours, or until the cervix dilates to 6 centimeters. At first, there are irregular contractions that occur every 5 to 30 minutes and last about 30 seconds each, causing the cervix to dilate from 0 centimeters to about 3 centimeters, and efface from about 0% to 30%. Then, regular contractions follow. They happen every 3 to 5 minutes and last about a minute or more, and this causes the cervix centimeters to This marks the beginning of the active phase of labor, during which the cervix dilates from 6 to 10 centimeters and faces to 100%. Contractions are very intense, lasting between 60 to 90 seconds each, with only 30 seconds to 2 minutes of rest in between. So sometimes they can even overlap a bit, with one contraction beginning before the previous one is done. Also, the amniotic sac often ruptures at this point if it hasn't already. Now that the cervix is fully dilated, we enter the second stage of labor. And this can be thought of as the pushing stage. During this stage, the critical thing is for the baby, and in particular, the baby's head, to navigate through the maternal pelvis. And this depends on the 3 P's: power, passenger, and passage. Power refers to the forceful uterine contractions. Passenger refers to the fetus, and passage refers to the route that the fetus has to travel through the bony pelvis. In fact, the relationship between the baby's head and the bony pelvis is so critical that human babies have evolved with unfused skulls just so their head can be as large as possible and still successfully and safely make that passage through the pelvis into the world. Now, there are a few factors that determine how easy this passage is for the fetus. First is fetal size. The critical factor here is the size of the fetal head. Also, there's fetal attitude, which refers to the way that the fetal body is flexed, not its personality. When labor starts, the fetus is normally fully flexed, which means the chin is on the chest, and they have a rounded back with flexed arms and legs. In this position, the smallest diameter, which is referred to as a suboccipitobregmatic diameter, presents at the pelvic inlet. Larger fetuses, and those that aren't completely flexed, have more difficulty making it through the passage. Next, there's fetal lie, which describes how the fetus is positioned in the uterus. A longitudinal fetal lie is ideal, where the long axis of the fetus, which is its spine, lies along the maternal long axis, the mom's spine. The fetus can also be transverse, where the fetal spine is perpendicular to mom's spine, or it can be oblique, where it's slightly at an angle. And these 2 positions can impede the progression of labor. Finally, there's fetal presentation, which refers to the first fetal part, called the presenting part, to descend into the pelvic inlet. Cephalic, or head first, is the first type, and furthermore, the most common and optimal presentation for easy delivery is a type of cephalic presentation called vertex, which includes complete flexion of the head as well. Also, there's breech presentation, which is head up, so the bottom, feet, or knees present first, as well as shoulder, where the shoulders present first. To make it through the passage, the fetus makes several positional changes, which are called cardinal movements or mechanisms of labor. Initially, there's descent, which is the downward movement of the fetus into the pelvic inlet. The degree of descent is called the fetal station, which is described in terms of the relationship of the presenting part to mom's ischial spines. The fetus moves from the pelvic inlet, which is about minus station, down to the ischial spines, which is station 0, and this position is called engagement. Then there's flexion, where the fetal chin presses against its chest as its head meets resistance from the pelvic floor. Next, there's internal rotation, where the fetal shoulders internally rotate by 45 degrees so that the widest part of the shoulders are in line with the widest part of the pelvic inlet. After the fetal head passes under the symphysis pubis, which is at about +4 station, there's extension, which is where the fetal head will change from flexion to extension. And then they move to about +5 station and emerge from the vagina. After the delivery of the head, there's restitution, where the head externally rotates so that the shoulders can pass through the pelvic outlet and under the symphysis pubis. And finally, there's expulsion, where the anterior shoulder slips under the symphysis pubis, followed by the posterior shoulder, and then finally followed by the rest of the body. This marks the end of the second stage of labor. The third stage of labor occurs after the baby has been delivered and involves delivery of the placenta to separate from the uterine wall. It's then carefully removed to ensure that there are no placenta remnants left in the uterus. Sometimes, several hours after delivery is called the fourth stage because there are major physiologic changes like adaptation to the blood loss and the start of uterine involution, where the uterus begins returning to its pre-pregnant stage. All right, as a quick recap, labor is composed of 3 stages. The first stage starts with true labor contractions and ends when the cervix is completely effaced and dilated. The second stage is the pushing stage, which ends with the birth of the baby. The third stage ends with delivery of the placenta.
Thanks for watching. If you're interested in a deeper dive on this topic, take a look at osmosis.org, where we have flashcards, questions, and other awesome tools to help you learn medicine.
All right. Breakdown of stages of labor I gave you guys on Tuesday. And here's some of the details about newborns. So most of them are 5.5 to 9.5 pounds. Our heaviest was 8.5, and that was terrible because at that size you do have some tearing and stitches are needed. But our first baby was 6.5. Isabel weighed 6.5. They get bigger as they keep coming. James was 7.5, and then Thomas was 8.5, and that was on New Year's Eve. So they all are given an APGAR score outside of the womb, and that's in the first 1 to 5 minutes after birth. And to measure that, they check heart rate, breathing, their reflexes, their muscle tone, color, and they'll get a 0, 1, or a 2, like just to make sure that they're doing well. And 7 to 10 is considered good. 5 to 7 is poor and may need medical intervention. A score of 0 to 4 is associated with neurological defects. So that could be if they have cerebral palsy or different things that they were challenged with by being born. So hazard, and I'll zoom on this a little bit. You guys should have these PowerPoint, but there's complications in pregnancy. There's sometimes frequent vomiting or hbse gravidium. There's also vaginal bleeding that can lead to spontaneous abortion in early pregnancy. And then vaginal bleeding in a later pregnancy, that's the placenta previa, where the placenta separates from the wall of the uterus. And that still can be scary. That happened to us with our first child, Isabel, and we thought it was a miscarriage because there's a lot of blood and mucus and guts. My wife had gone to the bathroom and came back crying. I was like, "Are you okay?" She's like, "I need to go to the hospital." We went in. The cool part was she was okay, and we were able to see the heartbeat for the first time. You could also have toxemia, and that's due to protein in the urine, or eclampsia, and that's gestational diabetes or intrauterine growth and retardation. Some of the other hazards could be maternal age. So we did all of these outside of that range. 8 was considered a geriatric pregnancy for pretty much all of the pregnancies. She was 35, 36, now she's 37. And that's some of the things that she struggled with. So nutrition has to be good, as we mentioned during the pregnancy. You want an extra 300 calories a day, and then you want to gain 25 to 30 pounds. So it's pretty much 1 pound for every almost like week, or 10 pounds a trimester. The last 3 months is high in protein. One thing that could affect you also is maternal stress and illness. So if it's a domestic violence situation, that can cause birth defects. If it's something else, that's where it could show up. Also, multiple gestations are riskier and have younger gestational ages. A lot of things to keep in mind during that. And then one thing a lot of folks don't know is that sexually transmitted diseases or illnesses can be transferred. So So the 15th is 2 weeks from now. So we're going to have a few of your things due. If you guys do your family history and your eco map, so genogram and eco map, and then figure it all out from there. Let's see where we're at too. So with sexually transmitted diseases, one thing that we often don't consider, and I don't think until college we were taught this, but if you do have a cold sore, and 80% of Americans do have cold sores, it is considered herpes simplex 1. And that is transferable to any mucous membrane. So and herpes simplex 1 and herpes simplex 2 can both live on the mouth, genitals, eyes even. So during birth, if you have a herpes outbreak, it can be passed to the baby. So that's why at the end it says STIs can be transferred. It's important to know because they might want to do a C-section to avoid having any of those things transferred to the baby. And that's interesting to say the very least. It's definitely something that's a caution at the time. And even if you are asymptomatic, it can be passed on. So doctors are very cautious. Like if you do have the herpes virus, just so it's not passed during birth, because that is a very stressful time. And it's definitely an interesting breakdown. I want to make sure you guys are on par because we're going to have 4 major assignments and the application to the social work program. So that's something to be considered. And then making sure that you guys are all set in here, that there's 2. And it looks like you're good. So and it looks like you're good. So some of the other physical hazards, drug use clearly is harmful to the mom, the baby, all of the above. So they call it teratogen, any agent, substance that causes a birth defect. It increases chance of miscarriage, low birth weight, cognitive abilities. And drug use can cause addicted infants. I wanted to show some of you guys what that looks like. And it's become an epidemic in the Midwest. So Ohio, Michigan, Chicago included. Cincinnati, we had a documentary that showed a lot of that and the breakdown of a lot of these folks that were challenged by heroin in general. And so here is one to show they also test for heroin in the mom system. And they had this Pulitzer Prize winning video about 30 days of heroin in Cincinnati. And I think it was just called 7 Days of Heroin. So it was 60 journalists to cover this story and how they played it. And it was a renowned video for the documentary that they had come up with, because nobody had really documented this to that level yet. I usually have to watch it through Facebook. It's kind of interesting, or USA Today. But there's a few Few channels that should, but the first poop. So this is something to be cautious of. In the past, they would take the baby from you if you had 5 or 6 months, any drug uses in those months, because you were obviously pregnant during that time. So a lot of them do test for that. All right, let me see if this will play for you guys. It looks like it will.
Born to heroin-addicted mothers. Courts will take children from addicted parents. Taxpayers will spend heavily to lock up drug users. People will overdose in gas stations and parks and school parking lots. It's the first day of another week of the heroin epidemic. Over the next 7 days in greater Cincinnati, at least 180 people will overdose. 18 will die. This is normal now. This is a typical week. Here's courtroom A in Hamilton County. It's the first stop for those arrested the night before on heroin charges.
It says the defendant did knowingly have in his possession a clear liquid or syringe which he admitted was heroin.
On this morning, as on most, 1 in 4 cases on the docket is directly connected to heroin. They come from wealthy neighborhoods and poor.
She had syringes in her vagina that she did not disclose.
They are young and old, parents and grandparents, sons and daughters. Sometimes they are here hours after they almost died from an overdose. Sometimes they don't make it to court. Heroin and other opiates kill 1 American every 16 minutes. That's more than dying in traffic crashes.
Cincinnati 911, what is the address of your emergency? 4980 Clinton Avenue, the Coastal Library. My children's librarian is asking for a document. She thinks that he may be overdosing. Hello?
Hello, Cincinnati 911.
Yes, please, sir. My brother and his friend overdosed.
Where's
In
the
my
man?
car. I'm lying around the room. What's going on?
Stay breathing.
The lights are blue.
I just walked into my buddy to answer his phone, and I believe he's OD, and I think he's dead.
Can you tell me for sure if he has a pulse?
He's ice fucking cold.
I got a phone call. She was all upset for it. I couldn't understand her. And I said, I think she's telling me my baby's dead. No, it's not going. No. I don't know. It feels like her soul was your body. It felt like somebody just blasted me in the chest with a shotgun. It's what it felt like. I guess they see so much. They just kind of like, well, there's another dumbass, whatever. Of course, I deal with this every day. We deal with this. I said, yeah, well, I don't deal with this every day. I don't got to deal with it every day and bury my child. Every day my child's dead. I don't deal with that every day. How would you know your child was dead? They did. As soon as I played it, I said, nah, it ain't time. He hadn't been using. He's been clean for a year. He said, Mom, look, I promise you, Mom, I will never do heroin again. He said, Mom, that stuff they got every day. He said, it's not heroin. He said, it's intentionally made to kill you. So what happened to me? I'm going to do is try heroin again.
By the end of the night, at least 20 people in greater Cincinnati have overdosed. 4 have died. In the early morning, Covington police raid a house for drugs and guns. It's a constant battle to keep up as demand for heroin rises. Heroin is big business, and cartels from Mexico want to cash in. They flood greater Cincinnati with drugs and rely on street dealers to find customers. Police go after those dealers, But if one goes down, another is always ready to step in.
There's an overdose right here by the church. You see a needle man? Yeah. That's usually what it is nowadays. You know, somebody laid in the alley. This is what it is now.
Heroin isn't just a big city problem. Small towns across Ohio and Kentucky have been devastated by the drug.
You know, when we started this ministry, we were so excited about just being able to do what God wants us to do. We didn't realize the magnitude of what we faced with.
Gerald Breeden created Firehouse Ministries to do something about it. His church welcomes all, including anyone seeking help with addiction.
And when I hear him talk, it's like it's a demon that's got them. You know, that it's something inside of them that's really evil that's forcing them to do what they're doing. And a lot of these kids, you know, are faced with that same choice, and maybe sooner than later with the way things are. The kids that we help in that ministry's problem, and heroin seems to be the greatest controlling factor. Somebody in their family is directly connected with drug culture, and these kids are faced. And I've also seen some families where not only the parents are using, but they're using with their kids. That is a really risky place for all of them to be. And I know for a lot of their lives, that just seems like a normal thing that, you know, my parent is using, my siblings are using, and it's an atmosphere that just creates a whole lot more trouble for them when they think that kind of lifestyle is normal. Father, we just want to thank you for the blessings that you give us. One, thank you for this day, Father, for these kids that come out. I just pray that you protect them and keep them safe. Draw them close to you and let them experience your love and your mercy. In Jesus' name. Amen. Amen.
By the end of the day, at 38 people have overdosed a week. 6 have died. As heroin addiction progresses, people lose careers, family support, even their homes. Some end up here, under the city's interstates.
When I started testing regularly, there was a lot of alcoholics and mentally ill individuals that weren't being medicated properly. Now it's mostly heroin.
It's Officer Tim Epstein's job to clear out these homeless camps, but he also tries to help.
These people are in a tough spot with their lives. Nobody really recognizes their rock bottom until it's pointed out to them. The goal isn't to take them to jail. The goal is to connect them to services. But sometimes I'll have to take people to jail. Each time you get evicted and have to change something, it's an opportunity to make the decision to make the big change, to actually get off the heroin or the other drugs that you're on.
Kim Hill is preparing to see the son she lost Monday to a heroin overdose. Tom had been drug-free for about a year before relapsing. His friends found him in his apartment, a needle in his arm.
Just to see your child looking like that and that had been doing good so long. I remember just laying on his chest and saying, why did you do this? Why? Always do this, Tom. You know, just laying there on him and kissing him. And I didn't want to let him go, and I didn't care how he looked. I just wanted to bring him home.
Crime labs like this one in Cold Spring are scrambling to keep up with demand. Evidence in every drug case ends up in a place like this, where it's tested, measured, analyzed.
You know, if they're really, really into it, this might not be enough for them for the day.
Heroin isn't the only problem. Synthetic opiates such as fentanyl and increasingly. Just a few crumbs are enough to kill. The idyllic suburb of Fort Thomas has had its share of heroin problems.
44, 43, yeah.
And the highways bring even more people with addiction through. Police created the heroin interdiction team after the drug was blamed for several deadly crashes in northern Kentucky. Drug driving is more common now than drunken driving. The right help can be hard to find for those addicted to heroin. Treatment centers fill up quickly, and programs that work for some addictions don't work well for heroin. The Campbell County Jail has a new approach. Women here get evidence-based treatment. They get medication when they leave jail. But that's not where it ends. For 2 years, they get health checks, job training, and housing assistance. Tara Jarvis deliberately got arrested so she could get treatment.
I completely shut down from everything, from my higher power, from my sisters, from my program. I'm determined. I want this money and work on one day.
What is the address of your emergency?
No, I'm in the parking lot of school, but it's like emergency. I think you overdosed. I don't know what you took.
I can remember waking up from being revived, and it was just literally like a fog of a dozen people standing around me. I had no idea who was who, and it was terrifying because it's almost like you're laying in a casket.
It took Amy Parker years to learn how to live without heroin. She relapsed more times than she can remember and alienated family and friends.
As long as a person is still alive, that they can get through this.
But she did it. She did medicine. Now she's a peer counselor, helping people who are where she used to be, walking the line between sobriety and relapse.
I'm in a dream. Is it real? And when I look around at my beautiful home in a safe neighborhood with my husband and my kids, it's amazing.
By the end of the day, at least 63 people have overdosed for the week. 9 have died.
Well, we're at 9 Mile and 52.
Claremont County Sheriff's deputies are targeting heroin users on US 52. Pill mills along this route used to give drug users easy killer. Those drug users come looking for heroin.
Since the heroin problem, it's just been the area that we've really had to target, and it just doesn't seem to be going good.
If you were at a beach, if you put your fingers down, say pinch some sand, and that's literally the amount of heroin that typically a user would purchase.
They'll shove that stuff down their small, shove in their cheek, bottom of their shoe, underneath the pad of the foot.
You know, it's true of finding a needle in a haystack.
And also for suspension for OBI, injury is here.
When deputies pull over this 23-year-old man, they find drug paraphernalia in the car. The man admits he uses heroin. He says he believes he's safe because he snorts heroin rather than injecting.
I just think that it's a lot safer than sticking a needle out.
So you're not doing it every day?
Yeah, sometimes, yes.
Sometimes, yes.
I don't know if that makes sense, but other times, no.
When babies are born to mothers addicted to heroin, they can suffer tremors, seizures, and other withdrawal symptoms. Children's Hospital treats those babies and works with parents to keep them healthy.
Still need a little bit of holding on, but you're getting there. There you go. Turn you on your belly and see what you can do. Eliana. Her name means gift from God.
Stephanie Gaffney says she used heroin for years until she learned she was pregnant with Eliana. She lives with her baby at a Cincinnati treatment center.
She gives me something a little bit more worth fighting for. I had a rough and complicated childhood. I don't want her to have to go through any of that I did. I want her to have her parents being consistent in her life. She looks excellent. You started out so little and you're so big now. Yes, you are. I don't know how possible it is, but I would like to have it as normal, but I would like to have it as normal family as addicts can have.
10 days after this visit, Stephanie Gaffney overdosed. Eliana is now living with Stephanie's parents.
No one wakes up one day and says, this is what I want to do. We don't see them as what most people would see them as, which is prostitutes.
Scarlett Hudson calls them her girls, and these women call her mama.
Yeah, so she'll be on the street tonight.
Through the Women of Alabaster Ministries, they can draw.
Broken. We don't believe at all that it's a choice that they would make had they had a good choice to make. This is one way that they know they've resorted to this. We see them. We thank you for the days when girls say they're gone. When you're sick and tired of being sick and tired.
Hey, baby, are you hungry? Oh, you want to go with me? I'm going to the building.
We know that if we keep doing what we've been called to do, that more and more of them will find their way out, and more of them will live.
There's going to come a day when it's going to be your day, and you're going to come in and say, I'm ready, right?
Yeah. They have aspirations and have had aspirations. We just gotta find that person again. So when we look at them for what they can be one day, not what they are at the moment.
I'm currently at Burger King on Glenway, and there's somebody passed out in the women's bathroom.
Are they sure this is a drug? Ma'am, they're passed out. They will stay down. Yes, the mule is right by her.
Most companies won't hire someone who's struggling. Most companies won't hire someone who's struggling with heroin addiction. Warsaw, Kentucky's largest employer, Dorman Products, takes a different approach.
We got 2 people here. Go on. What's your thing? I'll be clean.
I've been struggling with heroin for 7 years.
Workers need one company time to talk about their struggles or the struggles of family members.
I've got 4 kids, both my sons are addicts, and they have to be out and then some. So a lot of people just want to look at you and say, there's nothing you can do, just, give it to God and forget about it. Well, that sounds good, but it doesn't work that way, especially when it's your kid. Most of the time, it's an escape. You're hunting for the parts, and you only have a lot of time to think. That's the hardest part, is putting your game face on and trying to pretend like you're okay. In here, I don't have to do that. A lot of the guys that were in here will come up to me on the floor and ask me, how are your boys doing? Have you heard from Josh yet? And that means a lot, because a lot of people, they don't get it. My last job with one of the cashiers, she was talking about heroin addicts one day, and she made a very nasty reference, and I was like, I'm going to stop you right there. I have 2 sons, they're both heroin addicts. You're entitled to your opinion, but not sit here and listen to you say nasty things that they all should die and all of that. I pray that you're never in my situation, because only then are you going to understand it. And I don't want you to learn that way. Every single addict out there is somebody's child.
By the end of the night, at least 123 people have overdosed for the week. 13 have died.
We have a woman overdosed in our public restrooms.
Overdoses happen everywhere. This one is in the restroom at Finley Market. Someone finds a 35-year-old woman in a blue tank top and yoga pants sprawled on the floor and uses it to revive the woman. Usually it's the police or paramedics who have to administer Narcan. This man passed out while sitting on a bench at Pyatt Park. A bike cop spotted him and called for paramedics. Now, the cop is shooting naloxone into the man's nostrils.
There you go. You can hear me once you squeeze my hand.
Get up, baby.
Get up.
This is my baby.
Get up, Mom. Always doesn't work for a long time if they let their hand.
When paramedics show up, They insert an IV and give him another naloxone dose. This time the man rouses. Instead, at least 123 people have overdosed for the week. 13 have died.
You don't have him. I think the guy's dead.
Scary moments for a family driving southbound on I-75 near the Western Hills Viaduct. That's where Cincinnati police arrest a man for OVI on heroin after a crash.
Heroin users cause crashes all the time. Sometimes they shut down a major interstate. When this driver and passenger overdosed while headed south on I-75 while on heroin. Say heroin.
Hey! Ho, ho! Sheriff Jones has got to go! Sheriff Jones has got to go!
Sheriff Richard Jones won't let his deputies carry Narcan.
I'm a very compassionate person. I see more than they do. I cry a lot inside.
Jones is the only sheriff in Zone whose department doesn't use it. His protest from those who say saving lives is what matters most, and a counter protest from those who say heroin users shouldn't get free treatment, even to save lives.
Kids are born in my jail. 3 babies born in 18 months. Born addicted. 12 pregnant ladies in my jail and have 35 babies. One of them has 7. They don't have any of them. Children's Services has it. My politicians and our government does nothing. But I'm not apologizing for my stance, not even this much, and nor will
I guess that's part of being a kid, right? You're always
Maureen Sheriff's front yard is a playground for her grandchildren. Brianna is 9 and Jackson is 4. Natalie Bauer overdosed and died in January. Maureen is raising Brianna and her sister is raising Jackson. They consider themselves lucky to be able to care for the children. Kids of heroin users often end up in foster homes.
It is scary, raising a child without the parent. You don't know what to do.
So that they understand that they're part of a family.
People say it'll get better. It doesn't go away. It doesn't get better. I want Natalie back. It's nothing more. I want Natalie back. It's nothing more in this world that I want. I can't have her. Last night she was crying. I want mommy. I feel like my life is over. Verona was saying last night, why did this have to happen to me? Verona was saying last night, why did this have to happen to me? This is so unfair. I said, you're right, it is unfair. I don't know why this had to happen to you. They have to be so brave. If it took her life to bring theirs, then that's what her destiny was. Her life was worthwhile.
13 have died.
It's never good. They got him and running outside to get us, and she's breathing. No, she's not breathing hard. She's crazy. I thought I let my friend went a few shots of Narcan. They're about to give her now. We gotta get her on the floor. Come on, guys.
Pick up Gracie. 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 We're gonna give her a let's do it.
I think she got a new dealer. Yeah. Her new dealer knows her. Or she's been off for a while.
Mister. Watch yourself. You don't have to be in your arm, okay? Gracie, you overdose. Okay, watch your step. Big step here. Okay. Let somebody give you some heroin while you're sleeping. Okay, let's see that for us, okay?
It's a battle, as many in law enforcement now see it. Local jails are the overwhelmed field hospitals, MASH units where the casualties just keep coming.
The city see a big spike in heroin OBIs. From what I understand is they've had more heroin-related OBIs than they have alcohol-related. They're easier to convict too,
because most of the time they catch them either with a needle in their arm or they get Narcan to bring them back. And the only thing that Narcan works on is opioids. So.
I dedicate every day to the drug. Did about 7 or 8 ODs, you know. I should by all accounts probably be dead.
They don't stay here long. They get patched up and booked, but the jail is crowded. If they've committed no other crime, they are often released within days or hours. Many return again and again.
Thank you for stressing me out.
Lizzie Hamlin's son, Scotty, has been missing for days. His friend, Tom Tom, died from a heroin overdose Monday.
It's an empty room.
Scotty disappeared after that. His mom is sure he's using again. Lizzie came home from work just minutes ago and could tell that he had returned to the apartment. He left with some of his things. She suspects he used the money to buy heroin.
This is my room. I keep it locked. I keep my personal things in there. Leather jackets, brand new pants. Trade them and get money and get high. So we had our ups and downs, but we had a lot of good times. Respondent has track marks. He has been making up to 5 trips a day to purchase. He's going to Cincinnati 5 times a day for drugs and sometimes cannot make it through the night without using any couldn't. Approximately 3 weeks ago, respondent was admitted to St. Edward Hospital voluntarily and reported feeling hopeless, helpless, and felt suicide. The results in a 3-day stay was unable to stay sober longer than 6 days before relapsing.
Lizzie is going to Tom Tom's funeral tomorrow to support his mom, Kim Hill. But she'll also be thinking of her own son.
See, Kim's going through the process of her. She's having to plan this funeral. Me, I imagine in my mind, what would I put Scotty in? What kind of shirt would he want? What kind of hat would he want? What shoes? I just don't know. I don't know. I don't know the answer to any of it. If I could lock him to a bed with the chain, and I would. Scott, he just texted me back and said, love you too.
By the end of the week, at least 180 people have overdosed. 18 have died. This is normal now. This is a typical week.
We're here to pay next to Tom. He had a big heart, and he was all about family. Tom was here today. He could say anything you want to ask. He could say to those of you that are using heroin, please don't let this death be in vain.
Motorcycle mechanic. There's worked a great deal on.
So that's some of the details on the heroin epidemic. And we mentioned that challenge of drug use that can cause addicted infants, have difficulty actively engaging in their environment, increase use, risk for abuse. Alcohol is the biggest preventable cause of developmental disabilities. So fetal alcohol syndrome is one of the largest that we've mentioned before, and has a lot of problems associated with it. Also important to have the prenatal testing. So they do that in order to have what is needed to make sure the baby's developing safe that can be challenging. Also, some of this may require ethical decisions of to whether to terminate the pregnancy. So in Ohio, I know this PowerPoint was written in 2010. Right now there's the heartbeat bill, so it can't be terminated after 6 weeks when they detect a heartbeat. So that has changed since this old PowerPoint came out. Another thing on prenatal testing, they usually have a ultrasound or a sonogram, and they'll test alpha fetoprotein blood screening because that can show, actually could even tell you the gender of the baby. So they'll test for the X chromosome if that's in the mother's bloodstream. XY has a boy. If it's only X, it would be a girl. I also have a few others: amniocentesis, chronic villus sample. Timing and safety of administration of these different tests are important, mainly because if they're invasive or not. So non-invasive testing based on cell-free DNA analysis is a big deal. Also, the ethical dilemma. So terminating the pregnancy if a fetus has a major birth defect. Again, that's mostly available in Chicago and New York right now. So with the heartbeat bill in effect, it's not in as many states, maybe about half the states still. Some of the birth complications are anorexia and the potential causes. If you have meconium aspiration, and that means like breathing in the poop while birthing the kid, it could have potential respiratory complications. So they make sure none of that gets into the lungs. Malpresentation, if they look bad at birth. Perinatal difficulties, such as the cord wrapped around the neck. That happens a lot and cuts off the oxygen. That can really affect the baby. And then prolonged labor. So that can be exhausting just for the mother in general, because labor could take up to 24 hours and just is exhausting. So a few other slides here. There's high-risk infants. That would be one who has low birth weight, so less than 5.5 pounds, or premature, that's less than 38 weeks. One is intrauterine growth. And some of the challenges that come with that, those can definitely be extremely challenging. And folks do watch out for that. Also, the increased risk for developmental disabilities if this comes up. Also, the need to support children and parents. So as social workers, we really need to focus in on that to make sure we're supporting them in all ways that we can. And getting them the appropriate services. So just connecting them as a case manager. Some other consequences of premature birth, you could have respiratory distress syndrome, so that's RDS. Also, treatment for RDS must be provided with caution to avoid complications. There's one is retinotherapy caused by high oxygen levels, and then RDS children often are placed on ventilators. You can see babies on ventilators with that. And then also the bronchopulmonary dysplasia. It's a complication seen in children placed on ventilators. And again, as social workers, some of the programs we had at Lighthouse Youth Services was Help Me Grow. So that's specific to premature children. Also, some of the hospital social workers make sure to connect them with that program upon discharge after birth. So from the psychological dimension, this is the interesting thing. So this is where we talk about the fetus responds to pain, light, touch, and taste. At 26 weeks, they respond to sound vibration, demonstrates habituation, and recognizes the mother's voice at birth. Also, mother's emotions can affect the fetus, and depression, anxiety related to lower birth rate. And that's just knowing that there could be a struggle with some of the children that we're working with. Also, mother's emotions affect the fetus. 10% of the time, they're spent in the quiet alert state and learn how to recognize when the baby has had enough, particularly in the NICU, neonatal intensive care unit. And then there's a Brazilian neonatal assessment scale. And that's important because it's done when the baby is less than a month of age and baby's IQ with that. So, and we'll get on to some of the newborn characteristics soon, but just that they can focus on objects and some of the other challenges here. Here is the one on the Brazilian assessment scale, if it will play for me.
It is the most comprehensive assessment of newborn behavior that you will find. It's the only assessment that actually looks at crying in a baby and at sleeping and consoling, how a baby actually manages to console themselves. And it produces the most incredible amount of information. In fact, there are 53 scoreable items on the NBS, and it produces a behavioral profile of the individual baby. Because the point is, this is about the baby. Because the point is, this is about the individual baby. All babies are different. And you'll find that you actually find out so much more about babies that you never knew before. You won't believe what babies can do. They are so capable, interactive partners. And on the NBAS, there's also the fact that it's an interactive assessment. So in other words, you're showing a baby a ball, a rattle, watching how they react to things. And you can really tell if that individual baby feels very overwhelmed by, for instance, looking at a big red ball or hearing a loud noise. So you get a very good idea of how this baby needs the caretaking. What's the optimal caretaking for this, or caregiving for this kind? The caretaking. What's the optimal caretaking for this, or caregiving for this kind of baby? Is he a baby who really reacts intensely to bright light? Is he a baby who can't stand loud noises? Is he a baby who needs to be in a very quiet, calm, darkened room in order to open his eyes and look around? Or is he a baby who is saying, hey, just find the slightest thing very overwhelming? So I really encourage you to do the NBAS training. We call it NBAS, we call it NMAS, but it is the most wonderful, rich tool that you'll really enjoy doing, and you'll learn so much about babies that you.
Listening to the baby's voice, introduction.
So that's the neonatal testing there. And then here's one that they do. if it will play for us. Let's see.
First thing I'd like to show you is how Isabella can shut out disturbing things like too much light, too much noise. One of the ways we try out to see if a baby can habituate, do you know that term? Shut out disturbing or unimportant stimuli is to try repeated stimuli. You notice that she smiled the first 2 or 3 times, and then she moved her hands a little bit, and finally she began to open her eyes as if she was waiting for the next stimulus, which I think is fabulous because it shows that she's sort of anticipating. Now let's see if she'll. See her legs move. I could go on rattling for the rest of the day and she wouldn't respond because she's gotten into what I call a habituated sleep state. She put herself to sleep so she doesn't have to respond every time. They can shut out repeated noises. They can shut out repeated flashes of light to stay asleep. So they're working hard.
Mm-hmm.
I think they're learning through sensitive adult handling how to put themselves together. Matthew, quiet down, quiet down, quiet down, Matthew. Quiet down, quiet down, quiet down. It's a boy. I think that's what we model for parents by demonstrating it. That was so nice to see you calm yourself down by just using my voice. It's just so much fun to watch these processes go on and to see how complicated they are and how critical they are to that child's future. I think our work has led into conviction that the first 3 years are very critical as a base for learning later on. The newborn assessment was really probably the most important thing I ever did in my development for the field anyway. It changed our whole attitude, I think, toward newborns. Early babies are people.
So there's another one on diagnosing pain in infants. If I can get it to work.
How to
You always
open your
gotta
car
have-
door when you're trapped underwater. A lethal design after crash.
Pain is very tricky because unfortunately, pain, it's not like blood pressure. I can't just measure it like I do with high blood pressure. I measure someone's pressure, I know that their blood pressure is high.
Infants in challenge. They can't verbally express what they're feeling. Dr. Stork says they're more
All body movements, those are all behavioral aspects that tell us about pain. We also look at physiologic aspects. We look at blood pressure. The child's breathing very, very quickly. That helps to tell us that it's pain. We put all of those together and come out with scores that help us to tell how bad the pain is.
even with the scoring method, the outcome is always accurate. For example, the child could just be cold, hungry, or crabby. That's why doctors must also rely on the opinion of people who know the patient well.
Parents usually can tell if their child is uncomfortable and or in pain. And we almost always ask the parent how the child seems to be doing because that may be as good as some of our pain scores.
Once the doctor has successfully diagnosed a child's pain, there are a few simple and natural methods to treat it.
It's not always drugs. There are a lot of different things that we can do. Swaddling or comfort care, kangaroo care, skin-to-skin contact with a mother, that can be very valuable. What we call non-nutritive sucking, which is really just sticking a pacifier in the baby's mouth instead of a bottle, that can be very helpful too. These are all things that help to soothe the baby and to help comfort them. We found that simple measures like sucrose, just regular table sugar, dripped into the mouth or under the tongue of the baby, actually does seem to provide pain relief and may even increase the production of endorphins, which are natural opiates that are produced by our own body. And all of those things help a great deal in terms of taking care of the patient. In the end, we may still though need to use the powerful pain medicines that we use in older children.
Dr. Stork adds, the most important thing when dealing with a child in pain is to take it seriously, because untreated pain can become a bigger problem.
Anything that occurs to a child during infancy, when the brain is developing, when neurons are laying down, can affect the later development of the brain and the nervous system and can increase your susceptibility to pain later on.
Kelly Bowman, CNN.
First thing I'd like to show you is how his.
So you see a lot of the stuff that we're talking about early brain development. We're going to get into that the next chapter. We'll start it this week and finish a lot of it next week. But so attitudes and emotions and regulation, which that guy was trying to show how to get the baby to regulate itself. You've got colic, which is prolonged bouts of crying in the late afternoon and evening. It lasts from approximately 2 weeks to 4 months of age, peaking around 6 weeks of age. So there's the rule of 3, and to diagnose colic, otherwise healthy and well-nourished babies, it's crying that occurs for more than 3 hours per day, for more than 3 days per week, and for more than 3 weeks. So at 3, 3, and 3, it's something to consider. Some organic causes of the colic is 5% of cases like constipation, lactose intolerance, meningitis, and abuse. So if there is a baby just crying like that all the time, there could be some abuse going on. As a social worker, we need to assess that. Primarily the causes of colic are gastrointestinal, psychosocial, or neurodevelopmental. So it's kind of the early warning shot that we get into. So here's the several different newborn states. You've got quiet alert, then you've got active alert, the crying state, and then also the drowsiness state. You could also have a quiet sleep or an active sleep. And infants are used to sleeping in many environments because they use it to control the environment. So like if they are, babies seriously sleep 17 hours a day. So it's something to consider. A lot of these newborn reflexes, and you can look them up with a simple internet search or go on YouTube or Vimeo or even Rumble. Rooting, walking, crawling, palmar grasp, and doll's eye, and then the Moro, and let's see if I can get this copied here. Babinski, mnemonic net. But so doctors search a lot of times to show that the baby is reacting okay, and similarly. So here's one on some of the newborn reflexes.
Newborns are capable of communicating with their parents and caregivers from the moment of birth. When a baby is born, he or she comes to us already equipped with many capabilities needed to survive in this world. Some of these capabilities, with an infant's automatic stimuli in their environment. These reflexes are developed in the womb over time, which is why they're most often seen full-term newborns. While these automatic for several weeks to 1 year of life, the newborn reflexes eventually transition from being automated into actions that are consciously controlled by the baby. In this video, we will review the root, suck, tonic neck, grasp, step, and Moro reflexes. Each of these play a role in a newborn. The root reflex can be seen when one of the newborn's head open the mouth. The baby appears to be searching for something. The baby appears to be searching for something with their mouth or rooting. Since babies are very nearsighted at birth, this reflex helps them find their food source, whether it be mother's breast or the nipple of a bottle. The suck reflex is triggered when the roof of the baby's mouth is touched. The touch can come from mother's breast, a bottle nipple, pacifier, and even their own hand. The sucking is baby's instinctive skill to feed himself. It is important to note here that the suck reflex isn't fully developed in the womb until about the 36th week of pregnancy, which is why preterm infants or preemies can oftentimes have a weak suck and difficulty feeding. There are other factors that can affect a newborn's ability to suck, such as tongue tie, cleft lip or cleft, and even infection. Tonic neck reflex is sometimes called the fencing position because the baby's upper body pose or stance seen in the sport of fencing. When baby's head is turned to one side, the arm on that side stretches out and the opposite arm comes up to form an L shape. These descriptions make it seem like the tonic neck reflex will be a dramatic pose, but it's often a very subtle response. Don't worry if you do not notice this reflex in your baby. It may be produced better while an infant is resting, but even then it can be difficult to see. This reflex is just a protective factor for newborns, so there's no need to disturb them while they rest. The grasp reflex is much easier to see. Objects such as a finger, rattle, or blanket touches the palm of a newborn's hand, its innate response to wrap the fingers tightly around the object. This is the palmar grasp. You can even lay your fingers across the ball of the baby's foot and see the toes curl tight. This is called the plantar grasp. The step or walking reflex is develop muscles for walking later in life. This reflex is prompted by holding the baby upright under the arms while supporting the neck. When you hold the baby in this position and bring their supporting the neck. When you hold the baby in this position and bring their dangling feet to a flat surface, natural wrist to alternate lifting each foot in a stepping fashion. It looks like the baby is walking or dancing. The Morrow reflex is also known as the startle reflex because it's caused by just that. When a newborn is startled by a loud sound or sudden movement, they immediately jerk their arms and legs outward and then bring them back towards the center of the body. Depending on what position they're in, the newborn's head can even extend backward during this response. Babies get this reflex when they get a safety mechanism for the baby to protect himself from harm. In addition to growth and development, these reflexes play a key role in the newborn's safety. For example, the Morrow reflex allows babies to wiggle airways from being covered by outside objects. The root and suck reflexes help baby get to the breast for bonding and feeding. Please note that we do not expect you to test these reflexes on your newborn. As parents and caretakers, we can learn about our baby's inherent reflexes and abilities so we can be prepared to take care of them in the safest way possible.
So those are
When we
all
were using Monday.com,
of
our team was drowning.
reflexes.
Our days used to split between work
And with all of the reflexes shown there, again, you can look those up by searching newborn reflexes or each one individually. So some of the other strengths and hazards, there's a sensitive period just after birth called the golden hour. So what they had my wife and I do was hold the baby, preferably skin on skin, and also breastfeed the baby. So you produce like 3 stages of breast milk. There's like, the first one is for like the hour after the baby's born. Then you got another one for 3 days after the baby's born, and then it turns into the full milk. So importance of early mother-infant contact has impacted hospital birthing practices, including skin-to-skin contact and encouragement. 15 to 20% experience postpartum depression and anxiety. So that's for moms. And as a social worker, we need to watch out for that because there is some even postpartum psychosis where there is, harm to self or harm to others. Baby wearing is also a therapeutic tool. I wanted to actually show you guys something on postpartum depression because that's a big deal for social workers. And a lot of them do call it baby blues. And there's a few good videos on it. I wanted to show you this one as that seems most appropriate right now.
I battle with postpartum depression and anxiety. Asking for a friend. What's it like to battle with postpartum depression and anxiety? So my story began when I turned 30. Within the span of about 11 months, I got married and had a baby. About 6 weeks after I had him, I was having these depressive thoughts. My doctor kind of just told me that it was the baby blues and I would get through it and pushed me aside. I had reached back out to my doctor again, probably around 6 months postpartum, and my doctor pushed me away. So I, at that point, didn't really know what to do because I thought, I'm making this up, I'm crazy, my doctor doesn't think there's anything wrong, of course he knows best. So I tried everything I could to pull myself out of it. I started working out more, I went back to church and was doing whatever I could to basically survive. My son turned 1, I was in a really good place, and I find out that I am pregnant with my second. I had him, and the first 3 months were really, really good. Then it's like everything switched right at 3 months. What changed at 3 months? I was struggling. I was concerned about my abilities as a mother. I felt very overwhelmed. I used to call my husband almost every day, screaming at him to come home, like I couldn't take it, I couldn't handle it, like I couldn't handle the kids. I think it was about 5-6 months postpartum when I really hit rock bottom. I would think about things like jumping off of the balcony and what if I just like slipped down in the bathtub. But I didn't reach out to my doctor at first because I was turned away twice the last time. When were you finally able to get help? I called my husband one day while he was at work. I told him I was afraid that I might hurt my child and I didn't want to be here anymore and they would be better off without me. I don't think that he really truly understood how much I was struggling until that phone call. Thankfully, he called right away to a hospital. The psychologist called me. I shared with her on the phone all of the things that were happening. I was very honest. It was very hard to do, but I'm glad I did because if I didn't, I may not be here today. What was your treatment plan? The number one thing that they recommended was starting medication. I also had to stay on a plan with a psychologist. I stayed on the medication for about 6 months. Our insurance wasn't covering the medication. We just couldn't afford it. Thankfully, I was in a much better place at that 6 months, but I knew that I couldn't just not do anything. So I joined the gym. I was back at church again. I have not fully got into meditation, but I've definitely done things that are meditative, like learning breathing exercises, and noise canceling headphones are my saving grace. I also started seeing a therapist. She offered a sliding scale for me, which was amazing. It was definitely still a financial burden for us, but it was one cost as opposed to like the multiple costs with medication and a psychologist. It's probably been 2 years now, and I am in a completely different place. I still deal with anxiety, but it's not what it was. And so I think it's extremely important that more women are educated around postpartum depression because it affects so many of us. It's so important that we talk about the feelings that we're having and the things that we're going through because it could save your life if you know what to look for. Anything you want your kids to know about your journey? It wasn't easy, but because of them, I'm still here.
So that's one person's experience with postpartum depression. Here's the definition of it, because it is definitely a big deal.
Time for me to get set up for therapy, and I use this room as my office, but the desk is over here. And so when I'm seated at the desk, this is the background. I have my therapy session, which is virtual, and I find myself looking really forward to it nowadays because I found a therapist that
Today's topic is postpartum depression. Postpartum depression is moderate to severe depression in a woman after she has given birth. It may occur soon after delivery or up to a year later. Most of the time, it occurs within the first 3 months after delivery. Causes. The exact causes of postpartum depression are unknown. Changes in hormone levels during and after pregnancy may affect a woman's mood. Many non-hormonal factors may also affect mood during this period. Changes in your body from pregnancy and delivery. Changes in work and social relationships. Having less time and freedom for yourself. Lack of sleep. Worries about your ability to be a good mother. You may have a higher chance of postpartum depression if you are under age 20, currently use alcohol, take illegal substances, or smoke, as these also cause serious health risks for the baby. Did not plan the pregnancy, or had mixed feelings about the pregnancy. Had depression, bipolar disorder, or an anxiety disorder before your pregnancy, or with a past pregnancy. Had a stressful event during the pregnancy or delivery, including personal illness, death or illness of a loved one, a difficult or emergency delivery, premature delivery, or illness or birth defect in the baby. Have a close family member who has had depression or anxiety. Have a poor relationship with your significant other, or are single. Have money or housing problems. Have little support from family, friends, or your spouse or partner. Signs and symptoms. Some of the most common symptoms a woman may experience include feeling sad, hopeless, empty, or overwhelmed, crying more often than usual, or for no apparent reason, worrying or feeling overly anxious, feeling moody, irritable, or restless, oversleeping or being unable to sleep, even when her baby is asleep, having trouble concentrating, remembering details, and making decisions, experiencing anger or rage, losing interest in activities that are usually enjoyable, suffering from physical aches and pains, including frequent headaches, stomach problems, and muscle pain, eating too little or too much, withdrawing from or avoiding friends and family, having trouble bonding or forming an emotional attachment with her baby, persistently doubting her ability to care for her baby, thinking about harming herself or her baby. Diagnosis. Your doctor will usually talk with you about your feelings, thoughts, and mental health to distinguish between a short-term cause of postpartum baby blues and a more severe form of depression. As part of your evaluation, your doctor may ask you to complete a depression screening questionnaire, order blood tests to determine whether an underactive thyroid is contributing to your signs and symptoms, order other tests, if warranted, to rule out other causes for your symptoms. Treatment. Treatment and recovery time vary, depending on the severity of your depression and your individual needs. If you have an underactive thyroid or an underlying illness, your doctor may treat those conditions or refer you to the appropriate specialist. Your doctor may also refer you to a mental health provider. Postpartum depression. Postpartum depression is often treated with psychotherapy, also called talk therapy or mental health counseling, medication, or both. Psychotherapy. It may help to talk through your concerns with a psychiatrist, psychologist, or other mental health provider. Through therapy, you can find better ways to cope with your feelings, solve problems, set realistic goals, and respond to situations in a positive way. Sometimes family or relationship therapy also helps. Antidepressants. Your doctor may recommend an antidepressant that you take will empty your breast milk. However, some antidepressants can be used during breastfeeding with little risk of side effects for your baby. Work with your doctor to weigh the potential risks and benefits of specific antidepressants. Medication. When your safety is assured, a combination of medications, such as antidepressants, antipsychotic medications, and mood stabilizers, may be used to control your signs and symptoms. Electroconvulsive therapy, or ECT. If your postpartum depression is severe and does not respond to medication, ECT may be recommended. During ECT, a small amount of electrical current is applied to your brain to produce brain waves similar to those that occur during a seizure. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest videos.
Some migraine attacks catch you off guard, but for me, a stressful day can trigger migraine.
So the last one is about baby blues. That can be when it's less intensive.
I didn't know much about postpartum depression prior to giving birth. It just wasn't something that was discussed. I didn't want anyone to know, and I don't think I even talked to my family much about it. I think my mother only found out recently that I had even gone through, real postpartum.
Postpartum depression is a mood disorder. Any woman, regardless of her race, age, social, economic, or educational background, can be impacted by this condition.
In the first 3 weeks or so, I started noticing that I just felt just completely overwhelmed, stressed, and it definitely was not going.
Women experience the baby blues. Transient anxiety, worry about, am I a good enough mom? Am I going to be able to do this? Am I going to be able to resume my normal activities? Those symptoms go away within the first few weeks of baby. Postpartum depression may seem like it starts out that way, but the ruminations, the obsessions, checking locks sometimes, going to the crib, making sure they eat all the time, not being able to sleep, feeling disconnected from her baby or her husband or her family, becomes very problematic. She's unable to function. And those symptoms become daily and intrusive and are present within a month of delivering a baby.
I was a mess. I was crying. I could not seem to shake that sort of overwhelming feeling that I had. I think I always worried about something happening to my babies or me. I think it was constantly in my head then, like I couldn't relax. I was just very wound up and, kind of checking on them.
There's an overwhelming sense of anxiety as well as sadness. And there's also the tendency to isolate, and the chance for suicide is much greater in postpartum depression.
I learned about the NIH treatment study via the internet research that we were doing.
Postpartum depression can be treated by psychotherapy. It can be treated by medication. Individual therapy or group therapy can be a very helpful tool with postpartum depression. It's important for women to seek out help from a healthcare professional because that individual will be more prepared to either intervene immediately with a medication or to recommend other approaches to treatment.
I would like other moms to know that it's okay, it's normal if you do have it, it's treatable, and that to be active and seek help and that sort of thing. Because I do feel like if I had not sought treatment, it's something that would have sort of festered over time and more difficult to manage. If we talk about our experiences, if we're open about our experiences, then that sort of takes this mask off for other women to feel comfortable knowing that this is okay. Other women have gone through this and they're okay on the other end. But we need to engage in that conversation and continue that.
So there's a lot of hotlines just to make sure that folks don't be challenged by the postpartum depression. Here's the minute video from Mayo Clinic. So this is a well-known researcher.
You're exhausted, you're unsure if breastfeeding is going right, why is the baby crying? I mean, there can be a wide range, and we kind of label that as kind of the baby blues. So that's normal. Expect that to happen. And there's a light at the end of the tunnel. However, for about 15% of women, it goes beyond that. And that is what we would label as postpartum depression. If they start experiencing symptoms 9 months down the road, they don't necessarily relate it back to the pregnancy. But really anything in the first 1 year we would label as postpartum depression. Classic symptoms of depression, feeling hopeless, crying too much. Sometimes it just shows up as irritability. Of course, if you're ever having feelings of wanting to hurt yourself or wanting to hurt others, we need people to seek out help immediately. The biggest thing that I want to instill to women is that they just need to be open about it. They need to feel shelves, they're not moms. They shouldn't feel like failures. They just need to be open about it.
Excuse me. So, see if we can up. Lots of TED Talks. Nothing that has thrown off the channel at this point, but here's the completion of chapter 3. The social dimension, so like healthy babies need chapter 3. The social dimension, so like healthy babies need support and stimulation in the home. So you've got to help that brain development. Intervention program, stimulation in the home. So you've got to help that brain development. Intervention programs provide support, education, and encourage prenatal care, and it decreases the risk of abuse. Some cultural differences among newborns. This is a good question for discussion that you can put in for extra credit. Like, what's the difference between African American versus white or Latino babies, and like how they're brought up. One, they do call out as infant mortality. So the rates of infant mortality in the US are higher than most developed nations. Mortality rates were 6% for white, 14% for black, and then Hispanics were similar to white, 6.1%. The primary reason for white infants was congenital abnormalities, and for African Americans was low birth weight. So that goes back to the nutrition and how important it is early on. What contributes to these differences? More questions for discussions. And what are some policy implications we could have? Also, finishing up, there's social strengths and hazards. One big social risk factor is poverty, and then the biggest is domestic violence. So 1 in 4 women are physically abused during pregnancy. So there's more fights, more stress, whether or not they're going to keep it maybe. Then it also increases the risk for miscarriage, low birth weight, and preterm labor. And then prenatal information to obtain during the assessment as a social worker is gestation, birth, and the newborn. So just getting all those details from the mom. And that finishes up for chapter 3, where we then kind of dip over to infancy. So some of chapter 4, if it wants to work for us. Lots of stuff in infancy, because like so much fast growing going on, the baby growing up and the baby being challenged by things. So with social change and consequences for infants, there is high mortality rate. So for many, many years, they couldn't stop it. The main developmental task in infancy was survival. And that was as recent as when my dad was born. So 1945, he was pre-baby boom. And that's something to be considered. So rates did decrease dramatically with improved nutrition and control of infections and diseases. So really antibiotics. So getting a lot of those antibiotics, it was huge. Something to help out with. Increased recognition in the early 1960s about the consequences of poor early child development started getting published. So they started this Head Start program in 1965. That was a big deal because I think at that year there was only 2 billion on Earth, 2 to 3 billion. Since when I was born, there were 4 billion in 78. By 89 and 90, there was even more, like 5 billion, 6 billion by 1999, 7 billion by 2009, and then 8 billion now. So whenever we cross that mark, it's grown quickly because of the way we have served the babies. Some of the social change and consequences for infants are societal change, both parents working greater number of hours, greater number of unmarried women. So nobody's in the home anymore. There's latchkey kids, and then increased number of teenage mothers, increased substance abuse by mothers. Some of the policies towards childcare, you got the Lanham Act provided government support for childcare during World War II. Daycare programs increased in the 70s. That's kind of the movement when both parents could work and went to work, and divorce. Well, yeah, divorce was more often, abortion was legalized, a lot of things going on in the 70s. And then Child Care and Development Fund, CCDF, was passed. Also the Dependent Care Child Credit, that was one we even use nowadays. And then welfare reform efforts of the late 1990s. So I'm sure there's a lot of meaty stuff on this, and like you with searching some of these folks. They had to live off the grid just like that back then. That's Jake and Cole, but just like some of the stuff that has come up. There's some good TED Talks on it. I can't show that because it will shut down the YouTube, but there's a few on, like why those early years are so important.
Hi, Mark Barton, Sandy Hook Promise here. When the gunman shot his way into Sandy Hook Elementary School on December 14th, 2000.
Walk away or argue their case. Their survival depends solely on their capacity to look up from their cots with vast, innocent, beautiful eyes and charm their parents into caring for them. It's their power to attract love that ensures they will be fed and clothed, protected and kept alive. In exchange for this nurture, young children readily offer their parents or caregivers unconditional admiration. They naturally adore and are boundlessly impressed by those who pick them up and bathe them, warm their milk and change their sheets. They are in awe at these giant people who know how to turn on a washing machine and kick a ball over a tree. There is, at this stage, no innate desire whatever to question or doubt figures of authority. Given what is at stake,
It follows that small children are instinctively hugely sensitive to how well they are doing at getting their admired protectors on their side. If they feel they are loved, they can relax into themselves and get on with the many other pressing priorities of early childhood, working out how to eat solids, figuring out what a plug socket is, how a button functions, what words are, and how soap bubbles form. But if love is in more restricted supply, the picture grows a whole lot more complicated. There are childhoods in which, for a variety of reasons, parents fail to be charmed as they might be. They leave the baby to scream, they shout at one another. There might be violence and hysteria, lethargic despair and terror. The young child knows instinctively it is in grave danger. If the situation is not somehow corrected, in extremis, it may be left on a hillside to die. At this point, our biology initiates a desperate yet darkly logical process. The young child starts to try a lot harder. It redoubles its efforts to charm, to be good, to do what could be expected of it, to smile, to ingratiate itself. It wonders what may be wrong with itself to explain the parental disapproval and harm, and doesn't feel any alternative but to search in its own character and behavior for answers. At the same time, the child resists what might, from an adult perspective, seem like the obvious move, to get annoyed with and blame the adults in the vicinity who are not looking after it as they should. But such a bold thought does not belong to the defenselessness of the early years. We are in no position to mount a challenge to our protectors, but we can hardly reach the door handle, let alone turn on a tap. We need to have our own front door key and bank account before cynicism is a realistic option. It is far more intuitive to wonder why we are horrid than to complain of being unfairly and unkindly treated. Small children therefore naturally turn injury to the themselves. They ask not so much, why does my parent fail to care for me, as how might I have failed this admirable person? They hate themselves rather than doubt those who should be protecting them. Shame replaces anger. It feels on balance like the safer option. A vicious spiral of self-hatred then sets in. The unloved growing child wonders constantly about their faults. Their parent may be alcoholic, narcissistic, sadistic, or depressed. They may never cook a proper meal or shout intemperately from their bedroom. But none of that matters in the slightest. The parent is financially impressive. To explain the lack of love from the paragons of parenthood, it must be that the child is an awful person. They must be stupid and mean, selfish and slow, physically repulsive, and irritating and shallow. As childhood gets left behind, much of this dynamic is forgotten. The adolescent and young adult overlooks exactly what went on. They cannot necessarily think clearly of the early years, and parental figures may be keen that they never do so. The former child can't tell anymore that their feeling of shame has specific origins. It can feel like something they might have been born with, a natural phenomenon, like bad weather or the flu. Liberation awaits us when we dare to take on board a highly implausible idea that our self-hatred, far from being inevitable, is an internalization of early deprivation, and that far from needing to revere and admire those who denied us love, we are in a position to understand, to question, to be annoyed, and to mourn what we did not receive. We are not so despicable after all. We've just, till now, lacked any better ideas to explain why we didn't manage to charm those who should have loved us from the start. How to overcome your child.
So there is some of the stuff with some of the social consequences. So this infancy stage of human development is from birth to about 2 years old. So hallmarks are physical growth, motor development, vocal development, cognitive and social development. You have huge physical growth during the first year. Like literally you double and triple in size. Like from 7 to 14 pounds at 16 weeks up to 20 pounds by 28 weeks and then even higher. Growth and size depend on environmental conditions as well as genetic endowment. Birth weight is doubled at 5 months. So there it is. It's at 19, 20 weeks. Birth length doubled by 3 to 4 years of age. And at 2 years old, you are half your adult height. Some of the red flags are if you have a large head or small head size, that could be potential cognitive deficits, small height and potential genetic syndromes, infant brain. So the brain growth is the most critical to biophysical human development. At 1 year, it's half the size of an adult brain, and you've got billions of neurons. That's why they say give the kids so many different connectors. And then proper nutrition during this period of rapid brain growth is so critical. Getting them outside, exposing them to different learning techniques. Growth does not happen at the same rate all over. So that's an important one. So baby's growth from head to feet is the sepulchral, and then proximodosal is from a spine to the extremities. And that's important. And then the maturation theory is genetically programmed sequence. So some of these important things that we see, they genetically go. So there's a lot of milestones, and these milestones help us understand the normal or typical sequence of development. Those at the 50 percentile for the age does not take into account the quality of clinical experience need. The station is posture and sitting in the same positions. The gait is the movement. Helps us identify those who may be at risk for a developmental delay, not a developmental disorder. Those that cannot perform a task that 90% of babies can. So screening recommended at 9, 18, and 24 months. And that's just a lot of the good stuff that we have to look at. Gross motor development. So this involves large muscle of activities. A lot of those reflexes that we showed you will disappear by 6 months. So at 4 months, they roll front to back. 7 months, sits without support. 10 months, creeping while cruising around the furniture. 12 months, independent steps. 14 months, stands a different way. At 22 months, they kick a ball with a demonstration. They also walk backwards at about 1.5 years. And then at 2 years, a child can kick a ball, jump with 2 feet off the floor, and throw a ball overhead. Red flags are at 9 months, the inability to sit, and at 18 months, inability to walk independently. So here's the visualization of those. You see 0 months, they usually just sit here, and they start sitting up. 3 and 4, they start rolling over at 5, sit independently at 6 months. Here's some of the fine motor skills. So that involves a lot of these different things. So at 2 months, they hold on to a rattle place in hand. At 3 months, batting objects. 5 months, reaching and grasping objects. 6 months, transfers hand to hand. 6 months, transfers hand to hand. 9 months, bangs 2 cubes together. 11 months, throws objects. 12 months, the pincher grasps. That's where they pick up like the berry. 14 months, imitates back and forth scribble, 3 cube tower. At 22 months, closes box with a lid, imitates vertical line. And at 2 years, a child can create a 6-block tower, feed themselves with a fork or spoon, remove clothing, and grasp and turn a doorknob. Actually, my kids are doing that. That's how they run out of the house. So we're getting in trouble. So you assess the newborn's nervous system also right after they're born. And this will show if they'll do that development in order. So sleep, wake states provide useful information. Active sleep is the periods without eye movement. Quiet sleep is periods with no eye movement. Unstable sleep patterns have been observed in many types of atypical brain development. Early sleep patterns have predicted subsequent developmental outcomes. How can we tell whether a baby is developmentally delayed? Is another question for discussion. Then ages and stages questionnaires. What is infant mental health? So this is a new thing that literally they did not believe existed years ago, just like a lot of stuff. I got the noon Central State songs going off. But like this field promotes healthy social and emotional development. The 0 to 3 Diagnostic Classification Task Force was started in 1994. It defined infant mental health as developing the capacity from birth to 3 to experience, regulate, and express emotions from close, secure interpersonal relationships, and then explore environmental and learn in context of the family, community, and cultural expectations of children. So they have a couple slides dedicated to the mental health because abuse and neglect is a big problem with some. So I can get to search for infant mental health because they're doing more research on it now. So they even have programs at different places.
Infant mental health differs from traditional mental health in that we try to intervene early. We focus on prevention and health promotion for the very youngest in our care. Our goal is to try to make sure that families feel well supported. We can celebrate and build on their own capacities in order to help them to get off to the best start possible.
So I've been bringing Jay here since she was born. 2 days after she got out of the hospital, or the day after, she's been here. Our doctor's been the same doctor too. So it's been nice to keep the same people for her.
I think the best part is the communication, because even when we're not, we also can get an answer on something that we need help with. So it was always really helpful.
We really think about our patient as the dyad of the child and the caregiver. And so we think about, what can we do to help promote their relationship there. And so sometimes we have activities or games that we can offer, lots of partnerships with some of our local resources around promoting brain development and reading, and so books and color and things like that. And then as part of the Healthy Steps program, we also offer developmental guidance. And so we have a folder for each family that's particular to that age of the child that offers information around growth and development and ways that we can help promote that for their child overall.
Having specialists here in clinic that can come and meet families as needed, they can help schedule follow-up appointments, they can be part of the visits that I'm in there with as well, has really transformed the way that we deliver our pediatric care. Everything in one stop for families is really convenient for them. And they can always still have challenging behaviors, challenging developmental questions, things that as general pediatricians we have some training in, but also benefit tremendously from the expertise of those who really dedicate their whole professional career to understanding the dynamic between the parents and the children.
It really helps with the kids' developmental milestones, keep track of things. They're always helpful when she was anything I need, I could teacher, she'll respond right away. Or questions, just being that they have that extra help. I would definitely recommend Denver Health for all parents. It takes a village, and Caitlin is definitely part of our village.
So they've got quite a bit on infant mental health and some of the things coming up. On how do we counsel them as a social worker, and then really responding to the baby's cues, because if they go left ignored, the brain development does not occur. That's why it's so important to keep this part up.
Babies have lots of wonderful ways of letting us know what they need. Here we look at parents starting to recognize their baby's cues and responding sensitively to them.
I think at the start, I didn't have a clue one cue from another. With Luca, I've discovered that he needs a little kind of wind down time. If I see that he's getting tired, he kicks his legs and talks to himself when he's hungry. Yeah. And then other times, when he's, yeah. And then other times, when he's bored as well, when he just wants to, he's just fed up and he wants to change the scenery or just show him different things or look at a book or a teddy.
It's funny, he gives cues sometimes when he and cues when he doesn't want to be held and he wants his own space a little bit. And then other times when he's rubbing his eyes and moving his head from side to side, it's bedtime for him. Every baby is different, and I suppose like every person, and every person will communicate differently. I think you know your own baby.
Babies come into this world ready to communicate. All of your baby's behavior has meaning. For example, when your baby looks at you or looks away, when they coo, cry, or become fussy, your baby is telling you something. For example, that they may be telling you that they are hungry, tired, need changing, or lonely and want to be close to you. And spending time getting to know your baby's signs and how best to respond. Through everyday interactions between you and your baby, where you notice their cues and respond to them, you are helping your baby develop a sense of security, trust, and comfort in their relationship with you. It can take time, especially in the first few months of your baby's life, to figure out the meaning of your baby's cues. Like every other parent, it is not possible to always get it right. What will matter to your baby is that you are responsive and trying your best. It is always okay to ask for help from your GP or public health nurse if you are struggling to understand your baby's needs.
So that is the majority of this stuff. Here's some of the sensory things you can watch for the baby. So then we will jump on with the midpoint of chapter 4 next week. So let me know if you have any questions for your assignments, and see you guys then.